How's it going, guys? We have a past level question for hematology. Before we get started, please subscribe to my channel. I really appreciate it. Give it a like, really appreciate it. Find me on Instagram, Mehlman_medical, MEHL, and man_medical, links down below. Find us on Telegram. Links to the Telegram group and channel are down below. Now, so I clip 31-year-old woman, 3-day history of mildly productive cough and fever. She has a right lower lobe consolidation with dullness percussion, so we're handing you the diagnosis of pneumonia, lobar, probably strep pneumo, doesn't matter. She has lymphadenopathy of the head and neck, peripheral smear is shown. So this is what's going to go down. Our correct answer is Leukemoid reaction. Let me explain. OID means looks like but ain't. So it looks like leukemia, but it's not leukemia. In other words, this smear is showing us just neutrophils. This is neutrophilia. These are normal neutrophils. Okay, you could argue maybe this one that my cursor's on right now, you say, well, that's like more than 5 lobes. That could be hypersegmented. I sort of agree with you, but this is not B12 or B9 deficiency. Choice C is fucking wrong for B12 deficiency. Okay, these are normal neutrophils. Neutrophilia. So leukemoid reaction is when you have a leukocyte count greater than 30,000 in the setting of an infection. And the reason we say it looks like leukemia, but it's not, is because what's normal leukocyte count range? It's 4 to 11,000. And if you, let's say, have a strep pneumo, you could expect your leukocytes to come back 10,000, upper end of normal, no problem. 13,000, slightly elevated. Maybe you're septic, really bad, 18,000, 23,000. But let's say your leukocytes come back 44,000. You're like, wow, that's super fucking elevated. You're right. And when we get a leukocyte count that's super elevated like that in anybody, we think, oh no, could this be leukemia? So we think it's leukemia when we see those bloods. And then what do? We do a peripheral smear as part of the workup. And rather than leukemic cells coming back, we see just neutrophilia like we have here. And USMLE will show you a similar image. And you say, oh, thank goodness it's only leukemoid reaction, which is an exaggerated immune response to an infection. There's many ways the USMLE can write this. They can write it just as leukemoid reaction as we have here. They can write it as reactive granulocytosis. Neutrophils are granulocytes. Okay, so basophils, eosinophils, neutrophils, granulocytes. But when we say agranulocytosis, for instance, tangentially, that is essentially synonymous with neutropenia. We don't really talk about eosinopenia or basopenia. It doesn't really happen, okay? So the point is, you've got neutrophilia here, reactive granulocytosis, and they can write the mechanism as, quote, increased leukocyte release from bone marrow post-mitotic reserve pool. They want you to know that as the mechanism. So OID looks like leukemia, but it's not. If you do the bloods and you see a super elevated leukocyte count, it's going to come back all neutrophils, okay? So leukocyte count greater than 30,000, and you get what's called a high leukocyte ALP, which simply means that the neutrophils are working properly. It's an enzyme within neutrophils. If they're mature and normal, they're working, leukocyte ALP will be high. If you have something like CML, choice B fucking wrong, you have a low leukocyte ALP because neutrophils that are produced in that condition are clonally produced, clonal proliferation, they're more immature, they're not functioning properly, they're not producing the leukocyte ALP enzyme the way neutrophils normally should. So this is leukemoid reaction. You got to know it for USMLE. I'll quickly chop out the other ones now. CLL is fucking wrong. Okay, choice A. So they would show you smudge cells. It's pretty low yield. Like you'll know, oh, CLL, it's smudge cells. I think it honestly shows up like once in history across the NMEs. Like it's not a high yield image. The thing you got to know about CLL is that it's the answer in USMLE if they give you a super elevated leukocyte count where it's all lymphocytes and it's an adult. So let's say 62-year-old man and he has a leukocyte count of 90,000 where it's 89% lymphocytes, that's CLL. If they give you that in an 8-year-old, that's ALL, acute lymphoblastic leukemia. So they care about the age, ALL kids, CLL adult. And there's other 2CK, step 3 stuff, like you got to do quantitative immunoglobulin assay as part of the workup for CLL. Point is, wrong fucking answer. Choice B, CML, fucking wrong. I already talked about it a little bit, but you got to know the mechanism. Of course, your Philadelphia chromosome, 922 translocation, BCR-ABL, and it codes for an oncogenic tyrosine kinase, aka fusion protein. Really like that for CML. And it'll be the answer if they give you all the cells listed down the page on the lab report and you see a bunch of myelo sounding cells. So they'll list like 12 different lab values with the bloods, and you're like, I have no idea what I'm looking at. I'm like, well, which cells listed there do we not normally see? Okay, so you'll see myelocytes. You're like, yeah, I don't normally see that in questions. You're right. Promyelocytes, metamyelocytes. I'm like, yeah, aren't those like unusual? Like you don't see those typically on bloods, right? So all the myelo sounding cells, that's CML. Wrong fucking answer. Choice C, and as I will quickly just mention, same way we have smudge cells for CLL, for CML, you see what's called a motley mix or a soup, where it just looks like all different types of cells. As I already said, wrong fucking answer. Choice C, these aren't hypersegmented neutrophils, even though one of them, as I already mentioned, could maybe be it, but it's not. Sometimes USMLE can play tricks as far as, give you an unrelated presentation, but it's still B9 or B12 deficiency anyway. It's not the case here, but B12 deficiency, apart from strict vegetarianism or veganism, pernicious anemia, right? So that's when you have autoantibodies against your parietal cells, sometimes against intrinsic factor. The parietal cells make intrinsic factor, and you need intrinsic factor to bind to B12 in the gut, so they get terminal ileal absorption of B12. Choice D, Jarisch-Herxheimer reaction is wrong. It's fancy. Students tend to never miss the questions. Like they won't know like what diabetes they like won't know the difference between type 1 and type 2 diabetes, but they'll like instantaneously know what Jarisch-Herxheimer reaction is. So that's just when you kill spirochetes, such as syphilis with penicillin, and spirochetes. So we're talking Leptospira interrogans, Treponema pallidum, that's syphilis, Lyme disease, Borrelia burgdorferi or Borrelia recurrentis for recurring fever. But spirochetes, apparently, they're a type of spiral-shaped gram-negative bacterium. But when you kill them in the bloodstream, they can release different apolipoproteins, apparently. Or not apolipoproteins, lipoproteins, apparently, that can trigger cytokine release and give you an anaphylaxis-like response. It's not an allergy. It's just a cytokine effect. Wrong fucking answer.